Thank you so much, Ms. Sankta. Good evening, friends from India and from abroad. We reconnect again for the next webinar of Indian College of Anaesthesiologists. This is webinar number 161 and counting. Wednesday is something, the webinar has become so much a part of our life that we remember that Wednesday, 7 o'clock, there is a webinar and we have to be there, leaving all things aside. Well, today's webinar is an extension of the first webinar that we had last week that was on research methodology. And this also is the same because the topics there could not be covered in one webinar. So this is the second webinar that we have. And what we have the same team of coordinators, webinar moderators, Dr. R.S. Rautela. Dr. Rautela is from University College of Medical Sciences and GTBH Hospital, New Delhi. He is director, professor, and head of the department there. And he is ex-medical director of GTBH Hospital and ex-treasurer of the Delhi branch of Indian Society of Anaesthesiologists, joint secretary of the National Association of Critical Care Medicine, and associate editor for the Asian Archives of Anaesthesiology and Resuscitation, has more than 50 publications. He's reviewer for journals, many journals, and he has supervised more than 50 students for their thesis. His interest is in regional anesthesia and the airway management. The second webinar moderator that we have is Dr. Rashmi from the same department. She's a professor in University College of Medical Sciences and GTBH Hospital. She has more than 60 publications in national and international journals. And she is Indian Resuscitation Council Federation and American Heart Association certified instructor in resuscitation. She has 6 chapters in books, and she's the reviewer for indexed national and international journals. Her areas of interest are resuscitation, airway, regional anesthesia, obstetric anesthesia, and perioperative care. Now, the topics that we have today are something that most of the postgraduate students face when they are to write the thesis. A very important component of the thesis is the sample size determination. Sometimes the students take a similar study. Okay, the sample size 60 was there, and report that the study had done, with 60 patients and all that. But there is a very scientific method of determining how many patients are required to reach a level of significance which will be authentic, for the study. And we'll get a very meaningful and authentic, result from that, which can have implication to the study. And the second, equally important, is to conduct the common statistical tests. There are so many of them. We all write, the candidates write, this is SPS version, this, that. But what is that version? And what do we get from that statistical package that we are looking at? And which particular tests are suitable for the data that we have at hand? This is a very critical question again, and to answer these we have two very learned speakers. So I won't go into that. I'll hand over the mic to Dr. R.S. Rautela for introduction of the speakers. Dr. Rautela, it's over to you. You are muted, sir. Dr. Rautela, you are muted, please.
Thank you, Dr. Baljit. And I'll open today's second module of research methodology. And our first speaker is Dr. Amir Maroof Khan. He is a professor of community medicine in University College of Medical Sciences at GTBH Hospital. He has published so many papers. And he is an active member in a medical education unit of UCMS GTBH Hospital. And he will talk on the sample size determination. Now I invite Dr. Amir Maroof Khan, please.
Thanks a lot, sir, and thanks a lot to the whole team. Today I'll be talking about sample size estimation. So just give me a few seconds to share my screen. Okay, so sample size estimation is seems to be a very difficult topic because we find students struggling every time when it comes to sample size estimation. I am trying to talk with you about how sample size is not difficult and what are the things that make it difficult. They are not applicable on most of us who are in medical field. And nowadays with the softwares, it has become very easy. We just need to know some basic concepts and we can move ahead and calculate sample sizes for ourselves, for our studies. So we begin here. So don't be afraid of calculating sample sizes. At the end of the session, you will feel, हाँ इसको कर सकते हैं. It's not that difficult. So the first step is, what does our sample size depend upon? This should be very clear with the researcher that the sample size depends upon the primary objective. If our primary objective is not clear, then it is difficult to calculate sample size. So we have to frame our objective properly. And when I say that an objective is to be specific, it has to be measurable, as it was discussed in the last session also, that it should be measurable. So what are you measuring? How are you measuring? Are you comparing something, or you are just estimating something in your study? That should be clear with the researcher. If you are clear with your primary objective, nobody can stop you from calculating the sample size. Even when we go to a statistician, or nowadays softwares are replacing some of the tasks of statisticians. So when you go to a software for calculating sample size, it asks you certain things, whether it's a statistician or even the software asks you certain things. And those things can be answered only when we are clear about what is our primary objective. And also try to have only one primary objective for one study. You can have many secondary objectives as you want, but let us focus on the primary objective. So let me give you two examples here. The first example and the objective A and objective B. These are both primary objectives of two separate studies. I will take you all through this journey of calculating sample sizes. So let us see the two objectives and see how they are different. It is important to know the difference between the types of objectives so that you can know what sample size formula or software you have to apply to calculate the sample size, and what input you need to give to the statistician or to the software to calculate the sample size. So the first objective A, to document sedation and analgesic medications administered pre-op for children undergoing a particular procedure under GA. And the second objective, the second example I'm going to talk about is to assess the effect of one particular drug and another drug in comparison to placebo for decreasing a certain condition in gynecological procedures. Now, these are the two objectives. How are these two objectives different from each other? So this is the question that we should answer whenever we see our own objective, a research objective, the primary objective. We should try to find out that what type of objective is this. It will be clear as we move ahead further. So we should ask a very simple question, that do we want to compare some characteristic between two groups, or do we want to find out an estimate of some characteristic in a single group? So if we want to compare between two groups, then we have to go on a different path. If we want to find out an estimate from a single group, we have to go on a different path when it comes to sample size estimation. Now, let us go back to one of the objectives and understand what is our answer? So in this objective, can you tell what are we doing based on this question? Are you wanting to compare between two groups, or are you wanting to find an estimate in a single group? If you read this objective, you will find out that this research aims to compare the effect of one drug and another drug in comparison to placebo. So miltazapine in comparison to placebo and dexamethasone in comparison to placebo. So here we are very clear from this objective that this research wants to compare between two groups about certain characteristic. Here it is, there's a certain condition. So that is what is being compared. So there's a comparison. And if we look at objective A, to document sedation and analgesic medications administered preoperatively for children undergoing a certain procedure. Now, in this case, if you see here, we want to find out that what proportion of children undergoing this procedure they are being given pre-op this analgesia and sedation. So here there is only one group, a group of children which are undergoing a certain procedure. So by looking at the objective, it should be clear to us whether we are comparing between two groups, or we want to find out some estimate, maybe of a proportion. Here in this case, in objective A, you are trying to find out the proportion of children who are getting sedation and analgesic medications. So if we are able to answer this question clearly, that whether we want to compare or whether we want to estimate in a single group, then the life becomes simple. And then, so first I will take up this particular type of question. This is very common in many of the clinical departments, including anesthesia. There's always, we want to compare between one versus the another. And then you can very easily use a particular software. You can go to G-Power. It's a free of cost software. You can download it and you can use it. So let us go ahead and see what do we want, what will the software want, or even if you go to the statistician and there's a formula, you will need certain things. There will be certain inputs in order to get a sample size. Please remember that sample size is not magic, that you go and ask the statistician ki I am doing a study on diabetes, please tell me sample size. I am doing a comparison between dexamethasone and miltazapine, and please tell me the sample size. And the statistician tells the sample size, okay, you take 40, you take 50. No, there has to be some logic behind it, and that you have to provide certain characteristics, certain values. Now here in this case, whenever you have to compare between two groups, please see whether you are comparing proportions or you are comparing means. For example, if you look at this example, we want to find out that what there are two groups, one is miltazapine and placebo, one is dexa and placebo. So if we want to compare, what we are comparing, that what proportion of patients undergoing gynecological procedures, if they are given miltazapine, what proportion suffering from PSAS, and if they are given placebo, what proportion are suffering from PSAS. So if we are comparing proportions, then you need to have an estimate of the proportion of that condition in the two groups that you want to compare. So it happens that often when we talk to the researchers, they tell that if we would already have, if we already are having the answer, then why are we doing the research? If we want for the sample size, we don't have much data. That is right. Now the point is to be noted is that we just want an estimate. We don't want the exact value, exact answer we will find in our study. But we need to give some estimate. Now, from where can these estimates come? These estimates can come from a previously published studies. So look at previously published studies, and if you find certain things there, you can use that data. If you don't have previously published studies, no need to worry. you can have a look at the hospital records. If you are working in an OT, you are having some patients last 1 month, 2 months, 3 months, whatever records you have. For some patients, you might have given miltazapine, for some patients, some other drugs. So you can say, okay, what we think that in this particular group, the frequency of this is this. And in placebo, we expect that it will be more. And it will be like 20% more or 10% more, that the researcher has the freedom to decide when it is about placebo. So two groups, what are the proportion estimated? And estimate is going to be wrong. We don't need to be having a try to find out a perfect answer to it when we are calculating sample size. But we need to have some data. Even suppose if you don't have hospital records, then what will we do? What we do is first do a pilot. You do 10 for 10 subjects, patients, you give one drug. For the 10 other patients, you give another drug, and you find out what are the proportion in this that are suffering from a particular condition, and in the other group also what is the proportion that is suffering from a particular condition. And then that is your estimate. And you can write also in your sample estimation that as previously published studies were not there on this particular topic, we did a pilot study, and we studied 10 or 8 or 7 or 20 or 30, depending upon what type of question it is. You don't need to worry much about ki exact figure kya hai, 10 hi karna hai, 20 karna hai, 30 karna hai. It's an estimate. So whether you take 10 or 15, it depends upon your feasibility. But yes, certainly 1 or 2 is not allowed, because proportions फिर उसमें मिलेंगे नहीं. Suppose you do you try to do a pilot study only on 2 subjects or 2 participants, and then you will get either 0 or 50% or 100%. So at least 10 तक तो ठीक है, 10, 15, and then I will say feasibility aspect should come in. So if you have that estimate from either previously published studies or from hospital records or from some pilot study, that sometimes it happens that we don't have anything. And if we don't have anything, then what you are trying to do is then do an exploratory study rather than going for a hypothesis testing study that I want to compare and I want to find out which is significant at a point when we are saying ourselves that we don't have any data about anything related to this. If we are at that point, then it is better not to move ahead and do a hypothesis testing study. First do a piloting, and then you will go ahead and give the inputs that are required here. Now the other thing that is important is, one is type 1 error and one is type 2 error. Even if we don't understand type 1 and type 2 error, I will say it is okay, because these are the default values. In the last, I think 10-15 years, I have never seen that these default values changing. So we who are in medicine, the field of medicine, we should not worry too much about these things, but it is good if we know what does it mean. So type 1 error and type 2 error. Usually type 1 error by convention is 5%. And type 2 error is 20%, and power of the study is 100 minus type 2 error. That is why in most of the times it is 80%. So type 1 error, first I will talk about type 2 error. Type 2 error is, first I will talk about, I'll talk about power, 80% power. So power is basically if there is a difference between the two interventions, between the two drugs, between the two procedures, we should be able to detect it. So suppose there is a difference of, we expect a difference of 10%. So are we able to detect that or not? That is power. So our sample size should be such that it should be able to detect a difference if it exists. So that is what is called as power. If a difference exists between the two groups, but our sample size is not adequate enough to detect that difference, then we say we have committed an error, that is type 2 error. So type 2 error ka scope 20% hai, and type 1 error is the other way of looking at errors, where actually there is no difference between the two groups, but we will say that there's a difference between the two groups, and that is type 1 error. This is a serious error. If some drug is not effective, our study should not say that it is effective. That error we should avoid, and that is why it has been kept very less, only at 5%, less than 5% only, not more than that. So some error we will have to adjust for, because it's not a black and white word. It's a gray area. Different people have different values. The normal values range from one point to another point. So that is why we have to deal with certain uncertainties and certain errors in statistical calculations. So type 1 error 5%, type 2 error 20%. Now, I have talked about this. From where did you get these assumption values, these estimates? So we can get from these. Now, I will just show you that if you go to the G Power software, the first thing, the arrow, if you see the blue arrow, it shows the statistical test. So we will have to see what are we trying to compare. Depending upon what are we trying to compare, we can select the proper input box for giving the inputs in the sample size estimation software box. No need to worry about all the terminologies. We need to know only few things that I'm going to tell you here. So first thing, look at the statistical test. And then here, because we are comparing between two proportions, so if you see, I have chosen the proportions difference between two independent proportions, because I want to compare a condition between patients given one drug and the other patient group given other drug. So once I select that difference between two independent proportions, then this box opens up. Again, we need not worry much about it. So what we see here, proportion in one group is P1, proportion in another group is P2, and then we will at the right bottom, you are seeing the calculate. You will click on calculate and you will get the sample size. If you look at the other thing, power and alpha, so you will see power by default is 0.95, that is 95%, and alpha is 5%. So we need to change these values, and tails is one tail. We always use two tail tests. So if we move ahead, we change the values, tails, two tail test, and then proportion P2 is 0.74 based on earlier study, and P1 is 0.16 based on earlier study, and alpha is 5%, and power is 80%. So it is 0.8. And we want that equal number of participants should be there in both the groups. That is why this N2 by N1, what you see allocation ratio is 1. So the moment we put these inputs and we click on calculate, that is given on the lower right side, you see here sample size in group 1 is 11. On the right side, the arrow that you are seeing shows the sample size in both the groups and the total sample size. So without worrying about many complicated terminologies and concepts, it is very straightforward with the coming up of statistical software, sample size softwares. If we know certain basic concepts, we can very easily calculate sample sizes without going into all that confusion of formulas and this and that. Nowadays, even I have seen statisticians using statistical softwares for sample size calculation. It makes life easy, and especially for us who are not from that mathematics background. So when we write about the sample size, we will write as such that to estimate the difference between proportions in group A and group B for a type 1 error of 5% and power of 80%, sample size is 11 in each group. So this is the minimum sample size that we need to take if we want to estimate the difference between the two groups. And these values from where did we get? From previously published studies. If you want to compare means in two groups, if that is your primary objective, then in the G Power software, where I have selected two proportions test, here you see here, you have seen we have selected here the first blue arrow, difference between two proportions. Here we will click, and there will be a drop down menu, and it will say there will be an option of comparing between two means, and then you will select that, and then it will ask the mean estimated mean in one and the estimated mean in the another group, and also the standard deviation of both of these. And the other thing will be alpha and beta, and then you can calculate the sample size. Now let us look at the another example. So I began with this thing that you should know what is your objective. Is your objective to compare between two groups, or is your objective to find out certain characteristics, estimate certain proportion in one group? Here, if you see this objective, to document sedation and analgesic medications administered pre-op for children undergoing a particular procedure. Now, there's only one group of children. We want to know what proportions of these children are getting some kind of medication. This becomes a single group study. This is an estimation study. We want to estimate something from a single group. Here, we don't intend to compare between two groups. As I said, in the secondary objective, you can have comparison, but that will not affect sample size calculation. Sample size calculation is based on your primary objective. So if this is the primary objective, then you need to tell only one assumption: what is the estimated proportion in that group. And confidence level, by default, we take 95%, that if this study is being done 100 times, then 95% of the times it will lie between a particular range. So that is why we here, because we have only one group, so you have to provide estimation for only one group. And again, from where will you get the estimate? Earlier published studies, earlier published thesis, in the hospital records, or pilot study. I won't go and repeat all these things again. Now, for this particular thing, you can use EpiInfo software. It is again a free of cost software from CDC. So there you go, you download, and you can use StatCalc. That arrow is shown when you open the EpiInfo. This is how it looks like. You click on StatCalc and you go on population survey. Don't worry, you are not doing a population survey. I agree, but it uses this terminology because this software basically is for field epidemiology. But when we want to know about proportions, it will give you accurate and valid and reliable estimates about sample size for a single group study. So you can use this, and then when you click on this population survey, so this is for a single proportion. So it will ask you what is the expected frequency. And here, if you put the expected frequency, so that is what expected frequency simply means what is the expected proportion. So based on previous studies, suppose if it is 81%. So I've put here 81%. Then it will ask you another thing, what is the margin of error? Now, margin of error is that if we are expecting that the estimated proportion is 80%, so we will be 95% confident. If you remember that 95% confidence level, that is related to the margin of error. So we will be 95% confident that the actual value of the proportion will lie between whatever we find at the end of the study plus minus 10%. So plus minus 10% error we are allowing, because as I said, statistics deals with uncertainties, and we don't have things in black and white. We have to go with uncertainties and accommodate for the errors. So 10% error I am allowing here. Now you see, around 80% is the expected proportion. That is why I'm taking the acceptable error as 10%. I can take the acceptable error as 15%, 20% also. Then it will be 80 plus minus 20. Now what happens is, if your expected frequency is very less, for example, expected frequency had 10% or 5%, then I can't take error as 10%. Expected frequency at 10% or expected proportion is 10%, 5%. So if I take the error as 10%, it means 5 plus minus 10. So it ranges from minus 5 to plus 15. So what happens is that on one side it goes on negative. So if the frequency, if the expected proportion is very less, if the thing that you are trying to find out, the proportion is very less, that is 10% or less than 10%, don't keep the allowable error or acceptable margin of error more than 50% of the expected proportion. For example, if your expected proportion is only 10%, here it is 81%, but suppose it is only 10%, then don't keep your allowable error or acceptable margin of error more than 5%. Half still some roughly. For example, if the expected proportion is but if it is 5%, then keep the allowable error as 2.5% or less than 6%. So this is some rule of thumb that helps us, and also the statistics can use it. So if we put the expected proportion and the margin of error, then for 90, if you look at the table that is given here, for 95% confidence level, what we find the sample size is 50 and 95. This is the only thing that we need to give the input. Don't worry much about other things that can be done for theoretical purposes and understanding the things. But for us who are in the field of medicine, this particular thing suffices. For instance, how will we write it? For an estimated proportion of 81%, we will give a reference also for the line. If you have found it from your pilot study, you write it that we conducted a pilot study in our setup, and we say how many 10 patients or 20 patients or 50, whatever is visible, and you found that the estimated proportion is 80%, 81%, then you are using it for sample size calculation. If you are using it from a previously published thesis, you can say that we are taking this estimate from that. If you are taking this value from your hospital records, you can say that we are using it from the estimate is being taken from the hospital records. And at 95% confidence level and 10% allowable error, the sample size found is 59. In this case, the example that I gave you. So this is in a nutshell about calculating the sample sizes. Most of the times this will suffice because you will be comparing means, or you will be comparing proportions, or you will be finding out some proportion in a given group. Whether it is a randomized control trial, whether it is a case control study, whether it is a cohort study, you are comparing between two things. The sample size formulas, the sample size estimations doesn't differ. But yes, if there are some other types of study designs, some other because in anesthesia also there are other types of study designs that have come up. So for that you will have to use some other techniques for calculating sample size. We are not covering that here today. I will just touch upon one point, that is about because as I was discussing with Dr. Asha Tyagi ma'am, it was that we can talk about sample size, sampling technique also, but sampling technique most of the times in anesthesia it is randomized control trial. So you are randomizing between two groups and you are using some softwares for randomizing. That is perfectly fine. But blinding and allocation concealment, I think I will just tell about blinding and allocation concealment. Blinding is when, so once you have randomized, that is fine. So you have randomized. Blinding is when the researcher and so if the researcher does not know ki who has been given what. So blinding में आपको ये नहीं पता किसको क्या दिया गया है, what in which group a particular person falls in, you don't know. So that is blinding. So blinding you have done, and at the end the patient also does not know. If the patient does not know in which group that patient is, then that is called as blinding. Allocation concealment is at the clinic, in the clinic, when you are assigning the patient to the treatment, at that time there is a chance of selection bias. There's a chance that I know that okay, this patient is getting this, so the next patient will be getting this. At that time, in order to conceal that what is being given to the patient, what we do, we have some sealed envelope. In that we are keeping something written like A and B, and the next patient will be given envelope 1, the next patient will be given envelope 2, envelope 3, envelope 4. Now I don't know what is there in envelope 1, what is there in envelope 2, and what is the envelope 3 and envelope 4 when I'm sitting in the clinic, when I am giving the different treatment to the patient. So for the first patient which comes in, I open the envelope 1 and whatever is there A, then that person goes in A. If it is B, that person goes in B. That is allocation concealment. At the point of allocating treatment in the clinic where you are doing this randomized control trial, at that time we use allocation concealment. And blinding is we don't know, even we don't know what is A and B, what patients are getting, we don't know. So that is in a nutshell about this sample size, and something about this concealment and blinding. Yes. So thank you very much. I think there is a question here. One does not need to guess the effect size. What the clinician needs to know is what effect size will make her start using the drug treatment instead of the control. So who has asked this question?
Dr. Amir, we will do the question answer session later on after the
Okay, fine.
Asha's talk. I think it will be better.
Thank you.
Yes?
Thank you.
Okay. Thank you, Dr. Amir. Now I invite Dr. Asha Tyagi for her talk. Dr. Asha Tyagi is a director professor in anesthesiology and critical care in UCMS GTBH hospital. And she has published more than 100 publications of research papers in international and national journals. And she is the section editor of our Indian journal, that is JOECP. And she is the associate editor of BMC Anaesthesiology. It's an international journal. She is a reviewer of many national and international journals. And her interests area of interest are the critical care, obstetric anesthesia, and research methodology in anesthesia. She will give a talk on how to conduct common statistical tests. We know there are so many types of statistical tests, and to analyze any data of any research project, and suitability of a particular test is how to conduct a test that will be discussed by Dr. Asha. Dr. Asha Tyagi, please.
Right. Thank you so much, sir. So I will be trying to demonstrate on SPSS how to do these tests. And for that reason, because it's a software I have to pull up again and again, I'm going to play a pre-recorded session while I'm right here, and I'll be happy to take the question and answers at the end of it. My aim is that our residents should be able to do a few common biostatistical tests themselves by the end of this. Can we have the recording, please? Arises, why must you talk about trying to use biostatistical tests? After all, there are qualified biostatisticians, and it's an entire developed professional field in itself. I can find two reasons to do so. One is that if, and all of us must be conducting research, then it is worthwhile to be able to conduct at least the basics of it ourselves. Second is that in an era of evidence-based medicine, where we are basing our clinical practices on research, we must have the ability to interpret that research correctly. And for that, a certain mandatory knowledge of biostatistical tests, at least the common ones, I feel becomes imperative. What has always fascinated me is that biostatistical tests, we are looking at an entirely theoretical world of mathematical formulae and applications to actually answer problems which are existing in our real world, in our biological world. So it's actually an amalgamation of two entirely different paradigms. So having said that, to be able to apply a biostatistical test, the preliminary requirement is that I need to understand to what do I want to apply these. Now, since this is a PG assembly, we have largely residents listening. You all either are doing your thesis or you've done it, whatever, and you know that you collected a lot of data. What was that data? That data was just variables. And broadly speaking, there can only be two kinds of variables. Either it is something quantitative or it's qualitative. Now, as the terminology itself suggests, of course, quantitative is going to be something which is represented by numbers. Now, what is a little complicated, however, is that these numbers can be of two kinds, and hence quantitative data can be either continuous or it can be discrete. How I have chose to understand it over the years is that continuous is something which you can represent from 0 to infinity, which means on a number line. Let's look at age. It can be anything from 0.1 onwards, 1, 1.2, 1.4, 1.6, and similarly for weight and height. On the other hand, there may be certain numbers which are not really continuous. They are discrete, which means that they can either be 1 or 2 or X or Y or Z, whatever. Let's say parity, let's say gravidity, let's say number of patients or number of children. So this is a discrete quantitative data. On the other hand, when you talk about qualitative data, it is anything which is not present as numbers. Let's say gender, male, female. AKI is present, not present. Patient survived, did not survive. Patient died or survived. So these are yeses or nos, which I can code into a 0 or 1, whatever, but that doesn't make it a quantitative variable. The variable in itself was qualitative. What gets a little complicated is that this qualitative data, instead of being nominal like a yes or a no, can also be ordinal, which means when I arrange my qualitative data into, let's say, categories, I may choose to talk about presence or absence of low, intermediate, or high risk. So this then becomes an ordinal data. Depending on the type of data that we are using, the biostatistical tests will change in nature. Now, when you have quantitative data, you are essentially dealing with means. At the end of recording, let's say, age for 40, 50 patients, what do you end up with? You end up with age of every patient in that particular group. You're going to try and see what is the central tendency of this data, which means what's the mean value. And then you want to compare it to something. Let's say your clinical problem was that you have a drug A, which you want to test whether it inhibits the intubation response. Earlier literature has used a drug B in a certain group of patients, and it noted that after intubation, 1 minute after intubation, the mean arterial pressure was a mean of, let's say, 90 millimeter of mercury. What you decide to do or how you decide to approach this clinical problem is that you choose another group of similar patients, right? Just one single group, one sample you choose. You record the MAP 1 minute after intubation exactly the same way of giving drug A rather than B. And then, of course, you're going to have a mean of the MAP at the end of this. Let's say that turns out to be 96 mmHg. What do you want to do next? Logically, the next thing you want to see is that is this value of 96 any different from the value of previous reference 90 mmHg? You haven't conducted the previous reference, but you want to compare yours to that. So you want to compare the mean of a single sample with a reference value. And for that, we use something called a one sample t-test. Now, what I'm going to do is I'm going to pull up my SPSS for this and demonstrate as to how we will carry out a one sample t-test. Just bear with me while I change my shared screen here. Now, this is what an SPSS data sheet looks like. It looks pretty similar to an Excel, but actually it is not. It is very, very different. Now, every patient, just like in Excel, when you fed your data, every one row belongs to one patient. All his variables, whether 1 or 2 or 10 or 100, have to be within this one row. The columns belong to your different variables. Now, the difference in SPSS is, if you can notice, I'm pointing down. I'm trying to move the cursor in the center of the bottommost field and showing you that instead of sheet 1, sheet 2, like you see in Excel, here you see a data view sheet, which is this one. Or if I click on variable view, you see this. In variable view, it lists the names and the characterization of the different variables which you are trying to talk about. So let's say in the first column, I have filled up MAP. It's a numeric kind of thing, numeric data. So now To analyze it, I need to go back to my data view. On the data view, now go back. What did I want to do? I wanted to run a one sample t-test for my mean arterial pressure, which I have recorded here. Now, if you go to the topmost part of an SPSS sheet, you get these drop-down menus. Look at the topmost bar in dark blue. It has analyze written here. I click on that. It gives me a drop-down menu. What do I want to do? I want to compare means and proportions. How do I want to do that? It lists several tests. Now, we have learned that we need to put a one sample t-test. The moment I do that, it opens up two dialog boxes. On the left, it is a list of all the variables which I have put on my data sheet. On the right is an empty box. It says test variable. So it's asking me, what do you want to test? I want to test this mean arterial pressure. So I selected. I click on this arrow. So I move it here to my test variable box. Second thing below this is, now whatever I'm working on in SPSS, if you can see, gets highlighted by little blue boxes. So try and focus on that. The earlier test value was 90 mmHg. So that's what I want to see. So I'm going to now come to, I just click OK. It's going to open a new window. So SPSS now gives me an output window. And in this output window, you can see the test that I have run. It is called a t-test. Move down this rectangle. It says that what you have run is a one sample statistics for mean arterial blood pressure, what I had put the variable name as. For N, that means 40 patients. The mean is 96.6. Next column, standard deviation is 10.3. That's what you normally want to write, mean ST. And then you want to look for the elusive p-value. That's what we all understand. Move to the table below. It says one sample test. Now this is where it has applied the test. And if you start looking at different columns, here is the column which says significance. And it gives you the significance or the p-value as one or two-sided. Remember, for all practical purposes, you are reading a two-sided p-value. If time permits, we can talk about the one-sided also. And the value here is less than that magical figure of 0.05. It's less than 0.001. So yes, it is significant. So what do you conclude? You conclude that these two values are significantly different. That's it. So we just ran a one sample t-test. What do we want to do next? Now I decide to approach this problem a little differently. I'm still trying to see whether drug A is good to inhibit intubation response. The outcome that I'm looking at is the MAP 1 minute after intubation. But what I do now is that I randomize my patients to two groups, right? One receives drug A, the other receives drug B, and then I get a mean of this 1 minute MAP in both groups, and I want to compare that. Okay. Now, supposing I want to compare two means in two different groups. Both groups are not related to each other in any way. I still run a t-test, but an unpaired t-test. How do I do that? Again, it's going to be very simple. Let's pull up our data sheet again. The way you record your data now needs to change. You are still writing the MAP in the first column, but now in the second column, you need to tell me which group the patient belongs to, correct? So in front of every MAP, I have written the group. Let's say 0 and 1. Here are the two groups I have named. How will I remember whether 0 was drug A or 1 was drug A? So when you go to the variable view here, if you notice, for the group, under this, keep tracing it, under the label group, I have put that drug A is 0. So I'll never forget it. Let's go back to data view. Let us run. Again, analyze. I want to compare the means by independent samples t-test. So instead of unpaired t-test, SPSS writes independent samples and a t-test. How are we going to run it? Again, the left side, it lists all variables which you have compiled in the data sheet. It's asking for a test variable. What is my test variable? Mean arterial pressure. So right, it comes here. But now it also asks below this, the second drop box or the second empty variable you need to feed in is the grouping variable, which here we go. This is what we had written. So just move it to this, but it wants you to define the groups. So my group 1, I had named as 0. My group 2, I had named as 1. So now let's just run the test again. Takes a little time, depending on how large your test is, the time taken is going to differ. And then it opens up the output. In the output, again, it has run a t-test, but it's an unpaired t-test. What does it tell you about the group? Now it says that yes, it has analyzed mean arterial blood pressure, but in group 0 and group 1. For both, it has 20 patients. It'll give you the mean 90, standard deviation 7.8 in group 0, and 103 and 8.5 in group 1. So I've got the mean in both groups. What do I want next? Usually, I'm just looking for the p-value. So move down here to independent sample test. Now, when you read this, if you observe closely, there are 2 rows. The column where significance or p-value is given is here. Significance again, one-sided, two-sided. But you will see that there are 2 rows. There are 2 kinds of p-values. While the first row is called equal variances assumed, the second is called equal variances not assumed. What does this mean? One of the essential assumptions for a t-test is that the variances, indirectly your standard deviations, in both the groups should be same. Okay, it is not that in one group what is standard deviation? In a way, it is depicting how dispersed, how widely dispersed your data is, right? So I want whatever is this kind of dispersion should be similar in both groups. That is an essential assumption which must be met for t-test. So I assume that they are equal, and normally you all read off this p-value in the first row, two-sided. What happens if this assumption is not correct? Then SPSS tells you that it is not equal variances by showing that this significance value, the first SIG, this significance value, as you can read here, is for equality of variances. It is not for testing whether the means are equal. So if this turns out to be significantly different, if your p-value is less than 5%, then I need to move to the row below and read this p-value from equal variances not assumed, which may be different in certain cases. So we just put up an unpaired t-test. Now I like to complicate things a little more. So what I've done is I want to approach the same clinical problem in yet another way. Somebody says that, no, I want to test drug A for this inhibition of intubation response. I do want to measure the MAP at 1 minute as my outcome variable, but I want to see what is the individual response, which means in every patient, I want to measure the MAP prior to intubation and then at 1 minute after intubation. And then I want to compare the means that I derive for these. Now, what is the distinction in this kind of data? This is what we typically say pre-intervention and post-intervention data. Or let's say this data is paired. So even though you're going to think of these means as belonging to 2 different samples, actually they're not 2 different samples. These 2 samples it's the same patient. So it is a paired data. So does my t-test change? We saw what a 1 sample and a unpaired t-test was like. Now here, what we need to put is a paired t-test. So you need to be able to identify which t-test you require. Only you can do that. The software cannot do that. But once you know that correctly, you open up your sheet again. And how you have plotted now your variables is that you have a pre-test MAP now. In this column, I have put. In the next column, I put the post-test MAP. And for row 1, it is the pre-test and post-test MAP of same patient, because we said every row has to be one patient only, correct? What do I want to do? I want to analyze, I want to compare my means, but now I want to run a paired sample t-test. Now this drop box, what does it ask me? It is empty and it asks me, give me the pair. Which pair do you want to check? Give me the first variable, give me the second variable. So I want to compare my pre-test MAP with post-test MAP. And let's run the paired test. I'm sorry, you might have a little background noise. I'm so sorry for that, but it's beyond my control. So again, it's a t-test, but it's a paired sample statistics. And where do I read my, again, pre-test MAP, post-test MAP, it'll give you how many patients. It's very important to look at your N also, because you need to make sure that there is no missing value. You may have fed in 40. What if one was typographically wrong? Actually, although this must be checked, but cleaning your data, removing duplicates from master sheets, that's a separate topic which I can't talk of right now. However, both 40 patients, both have 40. Mean and SD for both pre and post is given. You can see in pre it was 83 mmHg mean, and after intubation it became 96.6 despite giving that so-called drug A. Now, is this significant? Let's look at this paired sample test again. It shows that now it's talking about paired difference. How much is the difference in the mean? Around minus 13, right? 83, 96. Is this difference statistically significant? Is it significantly different? Let's look at the p-value. Where is it given? Right here. Significance value again. Two-tailed, less than 0.001. Yes, it is significantly different, but unfortunately, the post-intubation one is significantly higher. So is your drug A effective? No. When I choose to look at it in this manner, with this design, and hence this statistical test, no, it's not effective. So after running a one sample, an unpaired, and a paired t-test, I just want to quickly recapitulate by giving you a different clinical problem. Supposing I want to now evaluate the serum creat, okay? In all the obstetric patients who are admitted to my ICU in my hospital, and I want to see that is this different than of the same patient group in other government hospitals, because the data for that says that an average is 3.1. So I already have a reference value and I want to compare in one sample these two means. What will I be using? One sample t-test. Now I decide I want to see that is there a difference in the same parameter, same group of patients, when they were admitted to the ICU versus when they are being discharged. So in the same patient, two values, paired t-test. Now let's say the same parameter, same patients, but I want to compare it to the non-obstetric patients who are being admitted to my ICU. So what do I look for? Which test? Unpaired t-test. Now here, I just want to mention one more thing. You may have come across matched studies. What is matching? Now in matching, what you do is that you are trying to match both groups with respect to certain characteristics which you feel may affect your outcome independently. Let's say I decide to see the creatinine for OBS patients in my ICU versus I want to compare it with those OBS patients not in ICU but in my obstetric wards. I must match them for age. They should be a similar age. They should be a similar parity. They should be a similar period of gestation. So whenever you use matched study designs, you have to use a paired data, even though they are two different groups. All right. Now I decide to change my study design even more. It is still an RCT. I'm going to do an RCT only. I'm going to use the drug A and the drug B, but I add a third group in whom I give a placebo. I still want to compare the means of the MAP 1 minute after intubation, but now I'm comparing 3 groups. What test do I use? So now I'm going to use a different test. It's not a t-test. It's a one-way ANOVA. Please remember that ANOVAs are of several kinds, and for this particular reason, multiple group mean comparison, it has to be a one-way ANOVA. And how do I run that? We will again go back to my SPSS sheet. What have I done now? I will still record the MAP of all patients. But now for the group, instead of 2 groups, I have 3. So if you can see, I've written a 0, 1, and 2. What do? Go to analyze. I want to compare my means, and I go to one-way ANOVA. What is it going to ask me for? Now, in your dialog boxes where you need to feed in data, it says dependent list. What do you mean by dependent? Dependent variable means a variable which is going to be affected by a number of things, correct? That is the one you're trying to study. So it's also called an outcome variable. So that's my MAP. Okay. Factor, which means how am I dividing this for the multiple comparisons? So what I'm doing is, it's the group, and now I have 3 groups. What ANOVA does is, it'll give you a p-value to tell you whether these 3 groups, whether the difference in the mean between these 3 groups is different or is it similar. But I also, if it turns out to be significant, need to know as to which of these groups was different. So that means once I have a p-value, I want to put in a test after that. That's called a post hoc test. So I also need to click which post hoc test. It will give you a large number of tests. More important than to know which one, you need to know 2 kinds of tests. One in which equal variances are being assumed, and one when variances are not assumed to be equal. Now, normally we are going in for the equal variances assumed 2 key test. When variances are not assumed to be equal, usually we run a Dunnett's. Just remember for the time being that if within that group you want to compare with the control, we use a Dunnett's. Let's forget it at the moment. We're talking about between group comparisons. So I've taken a 2 keys post hoc test. I want to continue. I go and say, okay, let's see what the output shows us. It shows us that yes, I ran a one-way ANOVA. Second thing it shows me is that for this mean arterial pressure ANOVA, which is the name I gave to the variable, between the groups, first row, between the groups, look at the significance value, it's less than 0.001. So yes, there is some group comparison out of these 3, some comparison between the 2 which is not similar. Which one? Let me go down to the post hoc test table. What does it show? Now, if you look at this in different rows, it has given you different comparisons. So here it is comparing group 0, which was my drug A, with group 1 when I compare here. Read the p-value in front of it, significance 0.03. So the value in 0 and 1 are significantly different. Is 0, which was drug A, also different than placebo, which was group 2? Here, 0, 2. Read the p-value. Yes. So 1 is different than 2 and 3. If I go back and I look at my means, I will know which was higher and which was lower. Similarly, you can read off for 1 being compared with 0, which I've already done. But 1 with 2 was not there in the first row. Here to 2. So I read off the p-value in front of it. It's 0.03. Even this is different. So this is how you look at the post hoc test to determine which particular groups are different. This is how I apply a one-way ANOVA. So after having compared means by these 3 different kind of t-tests and 1 ANOVA, we need to understand, which I mentioned a little bit in the passing, that for both tests, the sample must have a normal distribution. Now, what do you mean by a normal distribution of the variable or the data? If you can recall, in PSM, we all used to be taught this bell-shaped curve. What it implies is that if I was to plot all the different data sets which you have got, I was to start putting them here, right? They would kind of, and then I will try to cover all of them with some kind of a shape. They should all fall below this bell-shaped curve. So this is a normal distribution. What it implies is most of the values, 68% of the values, are centered around this mean. Okay, this 0 is the mean. Within 1 plus or minus of standard deviation. As you start going away from the mean, lesser and lesser values are towards the tail of this bell-shaped curve. So if I was to take 3 standard deviations on either side of the mean, I'll have almost all my values, right? 99%. 1 standard deviation, close to 70%. 2 standard deviation, 95%. So if this is a mandatory condition before applying my t-test and ANOVA to my data variables, how do I know whether it's normal or not? I'm not going to plot all my different, say, 100 age dots and then see, am I manually? No. Now, one very crude way of making out is, when you see your mean plus minus standard deviation, if you see that your standard deviations are very large, let's say your mean is 10 plus minus 8. So the standard deviation is almost equal to the mean. What does it mean? What does it imply? That for this mean value of 10 units, your standard deviation, so 10 plus 8, your last value is going to 18, right? On this extreme. 10 minus 8, 2, so it's here. So this is not bell-shaped. This is a very skewed data. Most of the data points are going towards one direction. So if your standard deviations are larger than 1/4 or 1/5 of your mean, it suggests that it is not a normal distribution. Best way to do it, you can run a separate statistical test called KS test, which again the SPSS gives you, or you could look at histograms and see. Now I'm going to just pull up the SPSS and we are going to work out on one any data to see whether it is normally or not normally distributed. Now supposing I'll check 2 variables to just show you what it looks like for a normal and a non-normal test. Analyze. I want to run a non-parametric test. Here it is written. Okay. What non-parametric? When you go to this legacy dialogues here, it gives you a 1 sample KS. This is what I'm trying to run. What do I want to check it for? Supposing I want to check my pre-test MAP. Is it normally distributed? I want to check my post-test MAP. Is it normally distributed? And I click on normal. Let's see what it does. Now in the output, you can see that it runs NPAR means non-parametric test. And here is the 1 sample KS test. So it has taken all the data points together. Remember, when you run a KS test, ideally, you should be running for all groups independently. If any one group has a non-normal distribution, your tests are going to be non-parametric tests. We'll come to that. So when you see this 1 sample KS test, look at the asymptomatic significant values, this 2-tailed one. When you trace it, you see that it is 0.2 for the pre-test MAP, okay? And it is 0.02 for the post-test. So p-value is less than 5% for the post-test MAP. This means that post-test MAP is not normal in distribution. Supposing we were talking about histograms earlier. Go to graphs, go to a chart builder, and I want to build a histogram to see the data distribution now. Okay. I want this histogram simple. So I pull it here. What do I want to see the histogram for? For post-test MAP, because it was saying that it doesn't seem to be normal. Let's see what it looks like. Okay. Here. So if you were to draw a sort of a curve, can you see the maximum value is not at the measure of central tendency. It is not in the middle. So it is definitely not bell-shaped. Okay. It would be skewed to this left side. So this is not normal. On the other hand, if I was to again try and construct a similar histogram for the pre-test, which we said was normal. Let's see what it looks like. This is the post-test, right? What we saw. Now look at the pre-test. Yes, it has a central tendency mean where maximum values are probably lying. So this is a normal. Now, having said that, we would like to check for the normal distribution using KS test for each groups before you can apply your t-test or ANOVA. If the KS p-value turned out to be more than 0.05, it was normal, and you go ahead and use the t-test and ANOVA. What happens supposing this was not normal in distribution? Well, then you are going to apply entirely a different set of tests, which are called non-parametric tests. Just like for t-test, you had distinctions, remember? When it was one sample, it was one sample t-test. Here, it will be something called sign test. When there were paired values in normally distributed, we were using paired t-test. Here, you will use Wilcoxon sign rank test. If you had two unpaired samples, what were we running? We were running a unpaired t-test. Here, you will run a Mann-Whitney. So whatever is the test, once you know which one has to be run, again, the second question, how do I run it? So I'll run one non-parametric just to show you how it has to be done. I pull up my sheet. I want to analyze. Remember, our post-test MAP was not normal in distribution. I want to compare it to pre-test MAP, which was normal. But even if one is not normal, we take a non-parametric test. Legacy dialogues. What am I going to do? My pre-test and post-test. Supposing this was in, let's say this was not pre and post, but it is just two unrelated values, which are not normal in distribution, and I'm trying to compare. Like I would have done an unpaired t-test, I want to do a Mann-Whitney for non-parametric. So I have two independent samples, correct? Yeah. So when I have two independent samples, what does it want me to feed in? Again, it wants the test variable, okay? And it wants the grouping variable. So for, so my non-parametric variable was post-test. I'm doing an unpaired. So I'll test this with the group. And what was my group? Let me go back because just two groups I'm taking. I'm running a Mann-Whitney. So I want the two groups here, which I will define as 0 and 1. I continue, I run a Mann-Whitney, okay. Again, very similar. It says a non-parametric test. It says Mann-Whitney. It gives you both groups. You must ascertain that the N is complete. There are no missing values. And then you go to the table below to read off the p-value, which is the asymptomatic significance value, less than 5%. It's significant. So the post-test MAP, this is just what I've termed it, can be any variable, which was not normal in distribution, is significantly different between both the groups. So we have run through a non-parametric test also. After this, let's change our problem a little. having dealt with one sample t-test, unpaired t-test, paired t-test for paired data, as well as matched groups, one-way ANOVA, and different kind of non-parametric, for which I showed you just the Mann-Whitney, which is for unpaired t-test. Let's go to how to compare two groups, let's say, for qualitative data. Let's change our clinical example a little so that we get rid of our monotonous, repetitive statements. Supposing I have decided that I want to see whether patients with CAD and without CAD, are they similar in terms of the incidence of having the blood group A? Okay. So what I apply when I want this association, I want to see is CAD associated with having blood group A. It can be any kind of association between two qualitative variables. Maybe I wanted to see is the presence of acute kidney injury associated with patients being pregnant. Okay, so what qualitative variables would I have? AKI, present or absent, pregnancy, present or absent. And at the end of it, I want to be able to say whether there is an association between pregnancy and developing AKI. So this association, most commonly, when we apply chi-square, this is what we are looking for. This is the kind of table you have in mind, correct? So what I'm trying to see is the association between two qualitative variables. Now, just pause a little and think. This is very different from the test for quantitative data. When you get this sort of a frequency table that you have constructed, correct? Presence, absence of qualitative variables. This is what I will make for my data. So let us call it, this is what is the observed pattern of frequencies, correct? Now, if there was absolutely no association between these two, there would be a frequency table where there's no possibility of this association. That's what the software does. It will create its own chance expected pattern or expected pattern of frequencies when there would be no association between these two. And then it will run a significance test to see that are these two, the observed and the expected frequencies, if they are same, that means my observed is same as my expected frequencies where I have made sure mathematically that there was no association. So if they're same, that means there's no association of the two qualitative variables with each other. If your p-value is less than 5% and significant, what does that mean? That means that your observed frequencies are different than the expected frequencies, and hence there is a significant association between the two qualitative variables. The second difference for running qualitative test. Now, we kept saying that when we were running quantitative tests for non-parametric tests, there were different tests altogether. If your sample size is small, that is another situation where your data is likely to be not normal in distribution. Okay, so with small n's, just like you need to run non-parametric tests for quantitative data separately, that's another indication for non-parametric. In your chi-square for qualitative data, there is no such distinction as far as the software is concerned. Actually, when the sample size is very small, you need to run not a chi-square for the p-value, but the Fisher's exact test. Thankfully, when you apply a chi-square by using SPSS, it gives you both as a matter of practice. Now, what I've done is I have made this data sheet for 2 qualitative variables. You call them whatever you want to. I have called it success and failure, which means either it is present or absent. When it's absent, I have called the outcome 0. When it is present, I have called it 1. Similarly, you will have your other qualitative variable whose presence I have marked as 0, absence as 0 and presence as 1. Okay. Now, whatever these 2 qualitative variables are, what I want to do is I want to analyze. Now, these are descriptive statistics. Whenever you talk of yes, no's, presence, absence, these are binomial in categorization, right? 2 possibilities or whatever, and these are descriptive. So how do you normally, male, female, when you think about it in your demographic tables, you talk about them as percentages. These are descriptive statistics. In descriptive, SPSS gives you the option to run a cross tabs. And what it asks you to do is that give me a row and give me a column variable so that it can construct those 2 by 2 tables, the observed and the expected. It doesn't matter, you put either qualitative variable in either of the 2. Supposing you also want the software to tell you the percentage. You want to automatically know that, okay, if patients with CAD were 20, okay, remember that 2 by 2 table I showed you, out of which 8 had blood group A and the remaining 12 did not have. I wanted also to calculate within the group how many had it, how many didn't have it as a percentage, instead of doing it manually. So you go to your statistics part first. I have selected chi-square. Then I can go to cells and I say that I want just my observed counts to be here. I don't want the expected table to show, okay? It is going to construct it. I don't want to see it. I also want the percentages within the row and column, supposing. I continue. I run the test. So it has run, the SPSS has run across tabs. It shows me that total I had 55 patients whom I have entered, which is correct. I know that there were 55. This is the 2 by 2 table it has constructed for your observed frequencies. So 1 qualitative variable, which I had called success or failure, is here. It is either absent or it is present. This is my other qualitative variable. I had said group 0 and 1, whatever. Now, in how do you read it off? That success or failure, absence. So it was a failure in 19 patients of group 1, correct? And in 4, my outcome was present. So once you have seen that failure was present in 19 of group this one and 4 of group so on, it also gives you a percentage within this qualitative variable and within this qualitative variable. So it is a 2 by 2. You swap the qualitative variables into row and column, it makes no difference, but the way you read it is going to change then. What are you interested in? After writing down these percentages in your table, you will probably now be looking for the p-value. So you come here. Now, if you notice, your software gives you this p-value, asymptomatic significance, 2-sided p-value, first row for the Pearson chi-square. This is what we read off. So it's less than 5%. It's less than 0.05. It's significant. What does it mean? That my observed counts are significantly different from the expected counts with no association. Hence, there is an association between my qualitative variable 1 and 2. Let's say this was CAD and blood group A. So presence of CAD is significantly associated with presence of blood group A. As I said, that Fisher's exact test is what you should be looking at, which is here, the 4th row, if this was a non-normally distributed qualitative data. Now, if you see in front of Fisher's exact test, it gives you this 2-sided p-value again. So calculating p-value is not a problem. The same test application gives you both. The problem is, when do I choose Fisher's exact? So if you look at this second table of chi-square and look at the footnote, it says that certain number of cells, in this case, it says 0 cells or 0%, have expected count less than 5. Now, for Fisher's exact test, I'll say this slowly. If any of your expected cells in your 2x2 table, if none of them should have 0 and 1, that is one mandatory requirement for running a chi-square. If it is 0 or 1, it will not give you the test only. SPSS will not run it. It will say not valid. However, if more than 1/5 of your cells, which means more than 1/5 is 20%. So if more than 20% of your cells have a frequency count of less than 5, again, that means your sample size is getting small in certain of those cells, then you don't run a chi-square. You read off the Fisher's exact. So if this footnote says this percentage of cells, what is written, if this is 20% or more, have expected count less than 5, then remember to read off the p-value of the Fisher's exact test here, not the chi-square. So we have understood that for comparison of qualitative, it is the chi-square. What you need to, what probably is a new learning is that when to pick up the Fisher's exact test and why. So if I have to summarize very quickly, when you have quantitative data, which is continuous, you learn to represent it as mean and standard deviation. After that, you need to must ascertain using a KS test or histograms or broadly looking at the standard deviations, whether it is normal or not normal in distribution. If it's normal in distribution, which means that bell-shaped curve, which means a KS p-value of more than 5%, you go ahead and run your t-tests and ANOVA, the way we discussed, which is going to depend upon how many groups, whether there's matching, whether there's pairing. If it's not normal, again, it is going to depend on whether it is paired, not paired, how many groups, and the tests will change. I did not talk about independently discrete data. Now, discrete data was like number of children in a family or number of patients or any discrete numbers like parity, gravidity. First thing is that always represent your discrete and non-parametric data as median and IQRs, not as mean STs. And the tests that you run for all discrete data is the same as you run for the non-normal or non-parametric continuous data. If you have qualitative variables, life is a little simpler because either way, on your SPSS, what you need to run is a chi-square. But remember that you will have to read off the p-value of Fisher's exact test if it is non-normal, which means if the cell count with expected frequency of less than 5 is anything more than 1/5 of all cells, which means more than 20%. With that, I come to an end of this, I hope, productive interaction. My aim was that I want to emphasize that biostatistics has a definite place in our clinical practice. This was a preliminary lecture. There's lots to it. I'm not a trained biostatistician. The field is fantastic. It is highly developed. But yes, common biostatistical tests, we should be able to understand and run ourselves if you're a little enterprising. And at resident, actually at all levels, I feel that knowledge is very liberating. So for that simple reason, I feel that please be aware of SPSS, buy it, start doing at least the common tests yourself. That will increase your ability to interpret research also. Learn to identify your variables and start self-learning for conducting biostatistical tests. And with that, I'd like to thank the organizers for kind of given me a chance to talk about something which I have always loved to talk about, but I think very few platforms in our clinical practice are willing to accept that this is also an area in which we can advance our own selves. So with that, thank you so much. And I hope that I have contributed significantly to today's session. Thank you so much. Thank you.
Thank you, Dr. Asha, for your detailed discussion on application of different types of statistical tests to analyze various data of the quantitative and qualitative variables of any research topic, and with the very nice carry-home message you have given. I also thank Dr. Amir for a detailed discussion on the topic and how to calculate some proper sample size for any research projects. I think, in my point of view, these two topics which were covered today's module are a very important and I think difficult part of for any researcher, I think. And I think we all take the help of the statistician to analyze these data, I think, for our research, any research project or any thesis. Now I thank both the speakers for nicely covered their topics and detailed discussion. Thank you very much. Now I hand over to Dr. Rashmi for a question answer session, please. Dr. Rashmi.
Thank you, sir. And thank you, Dr. Amir and Dr. Asha ma'am, for a very elaborate and easy to understand way of presenting. So I can see two questions in the chat boxes. The first one is on effect size, which was posed for Dr. Amir. It says one does not need to guess the effect size. What the clinician needs to know is what effect size will make her start using the trial drug or treatment instead of the control. Dr. Amir, would you like to answer this? And
yes, it's a very good question. Actually, it's not a question, but a suggestion here, and I agree with it, that one need not guess an effect size. As I said, sample size should not be a guessing game. It should be based on some estimates, and estimates are not guesses. Estimates are some evidence, it may be a crude evidence, I agree, but it is some evidence. So for effect size basically means what is the difference that is expected between the two groups. In simple words, if in one group it is going to decrease something by 20, in another group decrease something by 40, then effect size in very simple terms, the difference is 40 minus 20 is 20. We can talk about some, if I talk in the terms of purist, then it will be like we have to take standard deviation into account and the other things into account and sample size also. And then, but in simple terms, effect size is the difference between the two groups is what is the size of the effect or the effect size. So it should not be a guessing game. Yes, also we find that the experience of the researcher also counts at times. For example, how much should a blood pressure drop by in a particular, when using a particular drug, that we say that it is a significant drop. So whether it should be 10 millimeter mercury, 20, 40 in systolic, suppose systolic blood pressure. So the researchers, if the particular person is an expert in that field, so obviously whatever that expert will say will also be based upon the experiences from the hospital, from the background data and all. So I think that is perfectly right. What the suggestion is there, that effect size, it should not be just it not be only a guess, but the clinician should be able to define what is expected in one versus the another. Thank you.
thank you, Dr. Amir. I think the second question is also related to post for you only.
All the questions
Yeah.
are related to sample size, Amir, and let
Yeah.
me forewarn you, I can see they're all from Dr. Narayan, who,
Yes.
I mean,
Yeah, Dr. Narayan, I thank Dr. Narayan, and I think Dr. Narayan is also doing work on this, and It seems to be an expert on this topic also.
Yes, yes.
So it's great to have Dr. Narayana Yadana Pudi. I hope I am pronouncing the name correctly. So it's good to have these amongst us. So I think the point that is mentioned that no RCT occurs in vacuum, actually, Dr. Narayan agrees with this point. And so I will not touch upon that. I'll go on to the next point where I strongly disagree about doing a pilot trial. Pilot trials do not have any safeguards built into clinical trials. Yeah, fine. You strongly disagree. Actually, I strongly agree with your disagreement here that pilot studies are not definitive studies. But what I said was that in the context of calculating sample sizes, we need estimates. If in case we don't have estimates for calculating sample sizes, one is to drop the study altogether. Another is you conduct if you have 15 days, 1 month, some time, you conduct some pilot study in order to find out an estimate, not to find out an answer to that research question. So I will stop here for this point. And the fourth point, an alpha error of 5% isn't always appropriate. Yes, theoretically, you are perfectly right. I agree with you. But today what I was talking was mostly from the practical point of view. And I will tell you from my experience, I don't know what has been your experience, but last 10 to 15 years, I have never seen anybody changing that alpha value from 5% to 2% or 3% or 10%. So I will restrict myself here that my today's topic was on the practical grounds, how to calculate sample sizes. Theoretically, if you go, there are many things that we can come out, and it will take a lot of time. But for us who are not in having a background of mathematics, I think it should be sufficient. But yes, you can change the alpha, because at times that type 1 error, you cannot keep even 5%. You have to keep it 1%. That I agree that so 99% confidence we need to have in certain things. I perfectly agree with you, but I will say that this lecture, today's session was not for those who are much advanced in the knowledge of statistics and sample sizes, the theory part. And I appreciate your inputs and adding a new dimension to this discussion. Thank you.
Can I just make a point? Yeah. So when we talk in context of pilot studies, actually, as Sir has also been saying and Dr. Amir has been endorsing, it is actually a wrong practice to do any kind of intergroup comparisons when you're saying it's a pilot study. Pilot studies are meant to be exploratory in themselves, which means ideally you're not to be testing a hypothesis. You should just be giving your descriptive data. If at all you want to compare between groups, it should be at 1% alpha error. And there is enough papers about this. But yes, I know that we continue to do pilot studies and we continue to test them at 5% level, and we continue to compare groups and test null hypothesis. But it is not correct. It should not be done.
Thank you, Dr. Amir, for answering those questions. And thank you, Dr. Narayana Yadavanapudi, to have posed all these things and brought it to light to all the audience. Thanks, Dr. Asha, for your inputs. And now I hand it over to Dr. Rautela, sir, for conclusion.
Now, I invite Dr. Baljit sir for this vote of thanks. Dr. Baljit, please.
Thank you, Dr. Rautela. Well, friends, what a webinar it was. Very complicated as we see, because this is something that we are not trained at. We have been studying biology, we have been studying pharmacology, physiology, lots of other things which are related to medical science, but never been exposed to this kind of thing. It always seemed a very arduous task to sometimes, let me confess myself, to tell the students about the nitty-gritties of the statistical analysis. And the two speakers that we had today have made things a lot simpler and, to understand what are the details required in getting to that. First, of course, Dr. Amir Khan did a great job with the sample size estimation. I think this is the first thing with a postgraduate student, hits a wall, when he has to determine what is the size that is required for, sample size required for his particular study. And most of the institutions, I think, they don't have statisticians who are frequently available and who are experienced enough to give you a very clear answer at a short time. So students usually pick up from here and there, they pick up some study from there. So this is a similar data and a similar kind of study, and we are only changing the drugs and the rest of the things are the same. So they have taken 60 patients, so I as well might as well. So that's the kind of situation. But I think this talk by Dr. Maroof would have solved many problems for the youngsters who are listening to this. And the second one was how to conduct common statistical tests. Well, I think it was kind of a masterclass. And she was wondering if she has made a significant contribution. In statistical terms, I would say that she's made highly significant contribution to the understanding of these things. SPSS, I never honestly worked on SPSS. I generally ask the statistician that this is the data, kindly give me the values. And how to get to those values and what are the basic ingredients to classify your observations and to get the maximum information possible from those. I think this is what was highlighted by Dr. Asha Tyagi. Thank you so very much, both the speakers. Very fluent and very erudite, I must say, have in-depth knowledge of the subject, and you have done a great job for this webinar. And on behalf of Indian College of Anaesthesiologists, the President and the entire Executive Committee of Indian College of Anaesthesiologists, I thank both the speakers, Dr. Asha Tyagi and Dr. Maroof, and of course our webinar coordinators, moderators, Dr. Rautela and Dr. Rashmi Salhotra. Thank you so much. And we come to the end of today's webinar. Until we meet next week, once again, stay happy, stay healthy. God bless you all. Good night.
Thank you so much, sir. Thank you for the
Thank you.
opportunity.
Thank you, everybody. Thank you. Thank you.
sir.
Thank you, sir, and thank you, everyone.
Miss Sangeeta,
Thank you.
thank you so much. I'm sorry I'm missing out your name. And Miss Sangeeta, of course, for being the digital partner on behalf of Leonard. Thank you so much and good night.
Thank you so much.
Thank
Good
you,
night.
sir.
Thank you.
Good night. Good night, everyone.
Thank you so much, everyone, for extending us the opportunity to host the session. So with all your permission, I'm signing off here. Good night.
Good night.
Good night.
Good night.